Hello, I'm Frank Diamond. I'm the managing editor of Managed Care magazine. I'm here this morning at Princeton University talking to the world-renowned healthcare economist Uwe Reinhardt. And of course, we're going to talk about the Affordable Care Act. Professor, everybody knew something had to be done to fix the system. And everybody knew one of the main problems with the system was cost. Does the Affordable Care Act address the problem of cost, do you think?
The Affordable Care Act doesn't really address directly the issue of cost. In fact, of course, it would add expenditures. Other things being equal, it raised annual health spending by 5% for the extra insured. But what it did do, it developed a lot of instruments that could be used for cost containment. Now, it actually happens to be true that starting in 2002, the growth of healthcare spending in America has actually fallen, the growth. So when you draw a graph, you see a steep decline in the annual growth rate of health spending per capita starting in 2002. Economists who've looked at it, the bulk of that is recession-driven. There is a fairly close relationship between health spending per capita and GDP per capita, but with a lag. You know, it doesn't hit all at once. It's a long lag. Some of it hits in the first year, but it has about a 4-year lag effect.
Right.
But it tracks quite beautifully. The Altarum Institute and Kaiser people, they did some research, and it tracks very closely. And then there are additional things like increased cost sharing by patients through higher deductibles, and so on. There are a variety of things that started to lower the growth in health spending. It used to be that health spending annually grew 2 percentage points faster than GDP growth.
Right.
That's down below 1, sort of 0.5. So it's GDP plus 0.5%. And it might go to 0.8, maybe, when the economy recovers fully. But so something happened long before the Affordable Care Act was passed. But the Affordable Care Act offers, for example, comparative effectiveness analysis. Unfortunately, not cost effectiveness. That was ruled out by Congress. But at least you could say which drug works better than another. There are attempts of payment reform, bundled payments, rather than fee-for-service or capitation. The Accountable Care Organization, that's a more iffy bag. The idea there is essentially to build something like Kaiser, but without going all the way that Kaiser did, that it could be just contractual with hospitals and doctors. But notice what already happens. Only about half the physicians in America are still self-employed.
Right.
So there has already been this movement, and it predates the Affordable Care Act, of buying doctors and building larger system where you could have integrated care. But the Affordable Care Act accelerates that and gives incentives for that. So there's a lot in the bill that could help cost containment, but for President Obama to claim that it was an instrument of cost containment, or what we have seen is because of the Affordable Care Act, I don't buy that.
There's a lot of people in the managed care industry, in fact, the managed care industry lobbied to have allow health insurers sell insurance across state lines, basically become national healthcare organizations, healthcare insurers. Was there any credence to that, you think?
Well, I mean, you have to, what is it actually that is then being sold? What is being sold is states with very lax regulations of the insurance industry. If you go to New Jersey, New York, they really tightly regulate the insurance companies. You go to other parts, Iowa maybe, or Texas, where there's not that much regulation. There aren't all these mandated coverages of wigs and this and that that you might have here. So what you are selling is insurance with less regulatory protection. You know, that's what's being marketed. Because think about it, an Iowa or Texan insurer, when they insure a New Yorker, they have to buy the healthcare in New York
Right.
at New York prices,
Right.
which are high,
Yeah.
right? They're not like Iowa prices. So therefore, an Iowa company selling insurance to an Iowa person can quote a much lower rate than an Iowa company could selling insurance to a New York person, because they'd have to pay Mount Sinai and Columbia Presbyterian prices,
Right.
right? So the only reason they can be cheaper than a New York-based company is the less burdensome regulation of the state.
Right. You once told me a fascinating story about you met a man that was building a fence or a wall, and he was repairing the wall, and you said, "Why are you repairing the wall? Nobody's going to notice that the wall is messed up." And he said, "Well, I will know. I will know." And you point back to that old-fashioned craftsmanship. So, how much of our cost problem is cultural? I mean, how much it has to do with the lack of that old-fashioned kind of perfectionism? Is there any kind of tie in it at all, or is that too ethereal?
I don't think that's really the issue. If you look internationally, why do we spend twice as much as most European countries per capita or Canada? It's almost all prices. Name anything, and our price is twice of what it would be in Germany or in Canada, even for the same drug or the same procedure and so on. It's prices. And we wrote a paper, Jerry Anderson and I and some others, calling, it's quite famous now, called It's the Price is Stupid. It's in Health Affairs. Because we realized if you actually look, we have far fewer hospital days per capita than Germans or Canadians. We have fewer doctor visits. We eat fewer pills. The only thing where we consume a little more is some high-tech procedures like imaging and some heart surgery. We do more aggressive. And cancer care, we are more aggressive.
Right.
But in most other stuff, the kind you shoot at with cost sharing, we are already very dainty consumers. Americans don't flock to the doctor. We have the lowest physician visit rate per capita in the world.
So does that perplex you? Like, is this like one of those? I guess it is one of those problems that seem insolvable, or
I mean, have you ever seen a perplexed economist? We have an answer for everything. No. Here's my answer.
Yeah.
In all these countries, Canada, Germany, etc., the demand side, the payment side, has a lot of power. In Canada, it has what we economists call monopsony power, single payer. There's only one payer. And so the doctors in the hospitals, they negotiate with one payer. So the power of the market is all on the payment side.
right?
And the supply side is splintered. With us, it's exactly the other way around. The particular hospitals increasingly consolidate.
Right.
Well, the insurance companies are splintered. You could say Aetna is big, WellPoint is big. They're big nationally, but in any given market, they don't dominate. They may be relatively big, but somebody like Partners in Boston or Mount Sinai in New York, you couldn't write insurance without them in it.
Right.
And Mount Sinai knows that. And therefore, they have market power over even a big company like United. So, and I wrote a paper called Divide et Impera, Divide and Rule.
Right.
And I said, what we have done, we splintered the payment side into thousands of little payers against an increasingly consolidated supply side, particularly in the hospital area,
Right.
that has market moxie. And that is what drives these prices so high.
Our insurers, it seems like insurance companies and we at Managed Care have held them to task sometimes about some of the stupid things and decisions they've made in the past. You just mentioned that their power seems to be waning. Have they learned? Do you feel they've learned lessons of management in the past, and not only management, but how to get people not to view them as the bad guy anymore?
Yeah, I don't view them as the bad guy or as stupid. I've never thought they were stupid. No, it's just simply they were weak.
Yeah.
Because they were splintered.
Uh-huh.
And even their administrative costs are caused in good part by this pluralism that we have so many thousand different insurance policies, each with their own rules. It's an attempt to please the customer, but the more choice you have, choice is expensive.
Right.
And that is why I've seen papers. Our hospitals here spend twice as much on administration than any hospital anywhere in the world because of all this complexity. So it's not, I think stupidity cannot explain very much at all in our health system. Mind you, a Martian who would land here who would say, why the hell did they set it up this way?
Right,
you know, but everyone within it is quite clever, etc. It's just when you're splintered, like the insurance industry is, each guy sitting on the other side of a table of a consolidated hospital system is weak. I mean, you look even in Boston, Partners just owns that town.
Right.
You know? They're willing to negotiate, and they'll give you a little bit, but not a lot. Their prices are high.
Right. You just said choice is expensive, but it seems like in every other kind of endeavor, the more choice you have, that's the better for the consumer.
The more competition you have, the better. Not the more choice.
Okay.
Choice is always expensive.
Choice is always.
I mean, having all these toothpaste, if you had only 2 toothpaste, that would be cheaper.
Right.
But what is good that who makes toothpaste? Procter & Gamble?
Right.
I don't know, there must be somebody else who makes them. That you have competition tends to lower prices if the other guys know the prices. But that's another miracle of American healthcare. We don't know prices.
Right.
We know Medicare prices because, you know, at least you could know them.
Yeah.
But because they're in the public domain. But prices negotiated between hospitals and doctors are secret, trade secrets. So if you don't know prices, competition can't work.
Do you see an evolution toward you mentioned a single-payer healthcare system. You see an evolution toward that to address these?
That's what some people claim. I see it go the other way. If anything, we would go to a 3-tiered system where it might be that our kids, the ones I teach now, they might say, you know, you don't have to be 100% egalitarian in healthcare. You give everyone a guarantee to something. And so we'll have public clinics and public hospitals, and we budget them. And if you're poor, instead of being in Medicaid, you're in that. You go to that hospital.
Right.
And then for the middle class, you and me, you would have what is called reference pricing. You probably have seen that, where, for example, you negotiate prices with different hospitals, and you tell your insured, if you go to this hospital and that hospital and have your baby there, we'll pay 90% of the bill.
Right.
If you go to another hospital that's more expensive, you pay the whole difference between this reference price we would pay and what they charge you. WellPoint has just introduced that for CalPERS personnel, the state employees, in California. And it lowered only for 2 procedures, hips and knees, but it lowered the prices, I think, by something like 20%.
Wow.
And everyone else came down.
Wow.
Germans use that for drugs. So in Germany, they don't regulate prices. Everyone thinks Germans regulate prices. They don't. You as a manufacturer, you can charge anything you want, but you get put into a therapeutic group with lower priced. And the insurance company says, we'll pay you fully for the lower priced. You want this brand name that's twice as expensive, you pay the whole difference out of pocket. Immediately the brand name collapses close to the reference price. And that is what I think will happen to the middle class in America. And then boutique medicine for the elite, which they already have.
Right.
And I personally never begrudged them that.
Right.
I mean, why should a corporate CEO, when he gets sick, be in a ward when they've never mixed with humanity, as you and I know it, right? I mean, they have their limos, their jets, their mansions, and presidential suites in the Ritz when they go to Washington. You know, it would be almost cruel to say, when you get sick, we stick you in a ward. So I actually don't mind that at all, that they have a little suite up. In every hospital in America has that.
Or a Hollywood wing or something too.
Yeah, who cares? As long as they pay for it.
Yeah, right.
It shouldn't be taxed on that.
Right.
I don't think people would really begrudge people to have boutique medicine, other than if it really noticeably affected survival.
Right.
I mean, if boutique people got the hearts first before anyone else in transplant, that would bug people. But if they had luxury with butlers, I don't think anyone would care.
Well, as I mentioned, I'm here at Princeton University with Professor Reinhardt, a world-famous economist. And since I am on a university grounds, I have to
education.
yeah, boutique. Yeah, I have to ask you about what's going on in Penn State, because as you know, wellness is a big issue in healthcare these days, and there's a big stink at Penn State among the faculty that the wellness program that they've well, someone say imposed on the faculty goes way too far, way too intrusive. What do you think of wellness in general, and A, does it work, and B, should there be limits set to what they can ask you?
I think wellness programs don't work in every dimension. For some things, I think it's good. I think it's very good that people should know what their blood pressure is, glucose. I mean, the simple things that are really important to manage people's health. Blood pressure can be controlled. You know, glucose levels can be controlled. Obesity is growing. Weight can be controlled, certainly within some limits. The question is, should employers be the ones who do that? I think in America, employers do that by default. You don't see that in Europe.
Right.
The Europeans would deeply resent having your employer worry about your weight.
Or take your blood, or...
But I do believe insurance companies should be involved. We were in South Africa with Senator Bill Frist and some others. There's a company called Discovery Limited. It's an insurance company. And they have a program called Vitality. And in it, they give their insured targets. So within a year, you should lose so much weight. They actually have a personal health plan, and you have these targets. And if you meet them, you get a lottery ticket to a prize.
Right.
And the prizes are huge, 2 weeks in London, or really attractive prizes. So that's one thing they do. They do deals with supermarket and saying, if we send our insured to your supermarket, you give them 10, 15% discount on healthy food, not on the other. And apparently that really works. They're actually selling this program here. They sold it to Humana, this program. The insurer can do this because it's all around health. It's what it is. But I kind of hate my employer to know whether I did go to the health club, whether I did do this. I always say employers should make widgets and sell them and compete. And they shouldn't intrude. It sort of gets to the Nurse Ratched syndrome that you say you sit there in the cafeteria, eat a meringue pie, and somebody notices it. You know? Maybe they have little cameras
Maybe they're jealous.
Who ate the pie. You know? I think American employers stumbled into this by default. But I think it's sad. It's very sad. Employers should not be doing that.
Okay, and finally, I'd like to ask you, I guess in a macro sense, where do you see all this going from here? The healthcare costs, the ACA, I guess like in a job interview, where do you think that we're going to be in 5 years?
Well, actually, I'm actually quite optimistic about healthcare. First of all, it never was that bad a sector. People always say it's the most inefficient sector in the world. It's just all bullshit. If you compare healthcare to education, healthcare towers over education in terms of concern about quality, concern about cost effectiveness, etc. Compared to jurisprudence, have judges ever worried how much time of the jury they're pulverized? I mean, you know, so I think the healthcare system actually is a lot better than people claim it to be. You know, I always say we keep beating up on doctors and nurses, and they work very hard. But actually, where we should start, there was just an Institute of Medicine study out. They say we spend 190 billion more per year on administration than we should. It seems to me that should be attacked before I keep hounding more doctors and nurses. Now, there is unnecessary stuff, and people always claim that. But, you know, I always joke about the vertical and horizontal economist. When we're vertical, we talk a tough game, you know, don't do marginally beneficial things. When you're horizontal, even when you're an economist, you want all the tests. On an operating, you know. So, you know, it seems to me, do the low-hanging fruit, the thing that demonstrably couldn't hurt the patients if you went there. 190 billion a year would be much more than we need to cover all the uninsured.
Right.
100%
Right.
universal coverage. So that's what we should go after. For some reason, we talk about evidence-based clinical practice, but not ever about evidence-based administration.
Right.
And it seems to me what we really need is evidence-based administration. Say, how could you run an insurance system more cheaply than we do?
Right.
I would say, how much should we save? Whatever we're spending, cut it in half. It's achievable with some ingenuity. On the other hand, there's going to be a lot of innovation coming, made possible for two reasons. One, computational capacity has enormously increased.
Right.
We now increasingly know how to measure quality.
Right.
10 years ago, we really didn't, And the labor market, tragic or not, is sluggish now.
Mm-hmm.
In the 90s, the labor market was tight. Employers couldn't do anything because the employees, remember the managed care backlash?
Right.
Managed care was a good idea,
Yeah.
but the backlash. Now labor is kind of on the run in a way.
Right.
And it is much easier for employers to impose networks on patients or to, even cost sharing more. It's easier to innovate. And I think when I look at some of I go to these venture capitalist meetings, HealthSpotter I was recently at, and you hear the energy of these young people dreaming up innovations, IT-based, in claims processing, in wellness even, computerized wellness where you have some gizmo that speaks to your iPhone, and in your iPhone you get a graph that tells you how your weight's gone this month.
Right.
Stuff that people need. Make a game out of wellness, you see. I think there's going to be a lot of innovation coming down the pike. And even within biomedical research, I think you will have a lot of labor-saving innovation. For example, home care.
Right.
That you can do it electronically. And you don't need a daily visit to these people if the metrics that get radioed to some center look okay.
Yeah.
So I think, first of all, the bending of the cost curve, I'm persuaded it's actually more permanent. We always thought, well, it'll go up again, when the economy improves. I don't think so.
Wow.
I think costs are better. It's still very expensive here, under control than before. There'll be a lot of innovation. I love the kids I teach. I really do,
yeah.
The energy I see there. And then when I look at those, say, 30 to 40-year-old entrepreneurs, they're up at 6 running, and then,
gives you a lot of hope.
These guys.
Yeah.
I think they will change. We're coming into a different era. These people are more open to change. Don't forget, till now, the health system has been a cartel, a cozy cartel. Everyone knew each other. We're all in this together, and somebody pays the bill. I think those days are over. And it's always been said necessity is the mother of invention, right? You've heard that.
Yes, sure.
But for 40 years, invention was the mother of necessity in healthcare. Right. Somebody invented a machine that went beep, 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 rather than just beep, beep. And every doctor had to have the beep, beep, beep machine.
Right.
No more.
Yeah.
The way device companies and drug companies sell to hospitals isn't anymore to the individual doctor and his or her desires. It's to committees.
Right.
So I think things are changing. So I'm actually far more optimistic than I would have been 10 years ago.
That's great. That's great. I appreciate you talking to me this morning, Professor.
Great fun,
I'm Frank Diamond with Managed Care Magazine, and we've been talking to the world-renowned healthcare economist Uwe Reinhardt at Princeton University here. And thank you for joining us. Thanks.
Right.